Pathways to Housing PA as our presenters for webinar number 2 in our series, and this one is Harm Reduction in Housing First, a topic that has been asked about numerous times at many meetings, so we're excited about this. I think this one's going to be run a little differently than the previous one, and that is rather than holding questions to the end, Matt and Oksana are going to stop several times during the webinar and respond to questions. So you can ask them anytime you want in the chat. You'll have 2 places where you can ask them. Preferred is in the Q&A box. If you can find it properly, just put your question in the Q&A box, and Brendan will then read it to the speakers. Alternatively, if you're just only finding the chat box, that's okay too. Those questions will be visible to everyone, but that's not a problem. So just if a question crosses your head anytime during the presentation, just put it in. You don't have to save it till later, and Matt and Oksana will respond over the course of the presentation. So anyway, welcome everyone, both our speakers and our participants, and I'm turning it over to our speakers.
Great. Thank you so much, Barbara. And you guys can hear us okay? We're all right? Great.
I can hear you well, Matt.
All right, good. We're stepping up in the world. Last time that we did the webinar, and I shared a phone, and we passed it back and forth between the 2 of us. So now we have 2 different phones, and we're hoping that this will go a little bit more smoothly for us. But we are really excited to be back with you about this topic that's really, really near and dear to my heart. It's a core central tenet to Housing First, and it's something that's been an incredibly important tool in our toolkit and guiding philosophy to who we are as an organization, Pathways to Housing, and a lot of our partners are utilizing it, and it's something that I just really am very excited about, and thrilled that I get to share it with all of you today. I know that there's lots and lots of different kinds of experience, different types of workers that are on the call, and so please feel free to ask the questions as we stated already, and bring up anything that you want to address with us. This is also something that I recognize is at times can be pretty controversial. It's relatively new in the field. It has not been something that has been embraced for many, many years, but we are seeing that there's lots and lots of evidence to show just how important it is for bringing people into the field and helping to reduce the harms and risks that they're experiencing. So just as a quick reminder, an overview, my position, I'm the clinical director with Pathways to Housing. We are based out of Philadelphia. Oksana is our assistant clinical director. She comes to the work with significant therapeutic background, working with individuals with both severe mental illness and substance use. I've been with the agency for about 6 years, and really truly do love this work, and it's something that has been really exciting to be able to share with other people too. And because Oksana and I are on different phones now, we're just going to kind of riff off of each other a little bit. We've got some points where we're going to be speaking in different specialties throughout the presentation, but as Oksana please feel free to speak up if something reminds you, and then we'll also have opportunities for questions, and we'll stop and pause for those throughout. So Pathways to Housing, I don't think that we got really heavily into that previously. Let's see if we can come back to this. But just our overall mission as an organization is that our work is to transform individuals' lives by ending homelessness and supporting recovery for people with severe disabilities. This is a really broad definition and our mission statement, because we find that over time we have expanded our services quite a bit to serve new populations, to encounter new problems, but of course being the main focus is addressing homelessness. And in order to do that, we wanted support recovery as much as possible, a lot of times being using the tenets and skills related to harm reduction as we do so. I'm going to hand this over to Oksana here.
All righty. I just wanted to add to what Matt was saying when we work with people in recovery. And when we say recovery, we don't always only mean substance use. It's recovery from mental illness as well. So although the harm reduction philosophy was initially geared heavily towards the substance use and recovery and minimizing risks involved with certain behaviors, we are actually applying the same principles to the recovery from mental illness as well. So one of the key aspects of the harm reduction approach is using this person-centered language, and it's a way to build a more humanistic approach. We challenge our staff regularly whenever this comes up to continue utilizing the person-centered language. Like, for instance, if you hear someone say the word addict, we'll intervene and we'll encourage the staff to say the person in recovery or a person with a particular substance use rather than the word addict, because it does have such a negative connotation in it. So think of all the labels that our participants are given by either providers, the society in general. You hear a lot of labels when you hear in general about people who have mental illness or substance use related issues. It's easy to jump to judgmental language. It's something that we hear a lot, but as service providers, you really want to be mindful of your own language. How do you recognize your own judgmental like languages or like labels that you might be given participants, not because you intentionally want to demean them in any kind of way, but these are the kind of words that we hear a lot in the service in our field in general. What is the judgment that you may unintentionally show? What does that communicate to our participants? For instance, that very simple word, addict, again, it has such a negative connotation to it. Does that communicate something very positive to the participant themselves, or does this kind of say, hey, you are a labeled individual because you are struggling with addiction or substance use issues? It's important to recognize how your language impacts the therapeutic relationship. That is really, really crucial in your work, in your effective work with clients. In other words, if you don't necessarily use the person-centered language, it is going to negatively impact how well you develop relationships with your clients or participants. Another aspect to really think about is how do our participants view themselves and how we as service providers contribute to their views. Some participants are totally fine and okay to say I am an addict or I'm schizophrenic. One time I corrected one of my clients in the past when she said I'm a bipolar, and I had to really do a little education and work with her to help her understand that she is not the illness, but she does have symptoms and she does have certain behaviors, but that does not define who she is. Surprisingly to me, she really struggled with that concept because she was so used to being labeled. That's how everyone referred to her, every service provider she went to in the past. And we had a hard time helping her adjust to use that person-centered language about herself. So some of the things to really think about. Do you, in your work, or as in this harm reduction philosophy, you are in a position to be able to empower participants to challenge the labels that are placed on them. So, like, think for yourselves, have you had an opportunity to do that? Have you, do you recognize some of the labels that we give participants? Matt, you can do the other slide. Okay. Mine doesn't work. So a very, I'm sure many of these words look very familiar to you, but these are some of the most common labels that our participants are given: junkies, crackheads, alcoholic, right? It's such a common word that people use when they drink, but again, it goes back to what kind of connotation that word has. The one thing that really stands out in this slide is if you look at that phrase where it says clean and dirty, it's just simple things that we use a lot, right, in substance use field. But the word clean means something really pure. It connotes something that is good, innocent, and dirty has a very negative connotation. It means something really bad, something contagious, you don't want to be around it. So when you have a person who uses substances and you simply ask them, if I take a urine from you right now, is it going to be dirty? Which we can easily say, right? That's just going to give another message to that person that something is really wrong with him and there's something impure about him, something bad about him. So just little phrase like that makes a huge impact. Again, instead of saying a person an addict or a schizophrenic, you do want to kind of highlight the individual and the issues that they may be struggling with. A person living with schizophrenia would be a good example. A person living with depression or anxiety. A person living with substance use, something that you do want to kind of stay away from the addiction and dependence as well, because it does have a negative connotation. Again, people who receive treatment from any mental illness or substance use, people who are in treatment, even if they're not in treatment, but they're really trying to, they're in contemplation stage, for instance, they're really thinking about making that next step, they are the people in recovery. They are the people who are going to work towards getting the recovery under their belt. We used to term them addicts, really, or mental health patients. Anyone who's really working towards managing their symptoms, their behaviors, their illness is a person in recovery. So this is a very, this concept of thoughts, our thoughts impact the way we feel, and how we feel really contributes to the way we act, we behave, or we respond to other individuals. So we thought it would be really good to put this slide in here to talk a little bit about raising your awareness on how your own thoughts about your interaction with a client or a participant is going to trigger certain feelings, and those feelings are going to make you respond a certain way to an individual. For instance, if you have a client or a participant who is yelling at you and while you're trying to complete paperwork with them, you might think, the thought you might have might be, this person is really disrespecting me, or they're being disrespectful to me. So that particular thought may trigger a couple different feelings. It could be anger, it could be that you're upset or disappointment. Let's say you become angry. The feeling that it triggers is anger. And that particular feeling is going to dictate how you respond to the individual. If you're not aware of this chain, you can easily become defensive. You can start really pointing the fingers at the client. The things they're doing wrong are not doing enough of, just to take the attention of yourself. So important to recognize your thoughts trigger certain feelings. Your perceptions about participants and their behaviors trigger certain feelings. Those feelings contribute to the way that you respond to that particular individual. And recognizing that there's this idea that there are adaptive reasons for each behavior. Like, instead of when you get angry with that participant, instead of taking it personally, you may think to yourself, what other reasons might this person be yelling at me for? Did they have a bad day? Maybe they're going through a withdrawal, or maybe they're hearing voices that are telling him or her to yell at you. So when you really take your time to understand the reasons why that person might be behaving that way, it's going to diffuse that tension between the two of you, and it's just going to put you in a more advantageous position to build a trusting relationship with that client.
So we have, we're going to do just a really, really quick revisit to some of the housing first premise that include a few things that are tied to our overall principles and our guiding philosophy, and they're very, very aligned closely with the overall principles of harm reduction, and harm reduction, of course, being one of the big ones in Housing First anyway. But I just wanted to highlight them as we're discussing this. Of course, it's immediate access to housing. There's no requirement for abstinence within Housing First. This is this again is kind of an adjustment from a lot of the more traditional models where you have to, you do have to require, or a lot of times people are graduated into a variety of things, but then what do we do in the midst of that? Well, we have to figure out adaptive ways to minimize risk for a person and so that they can still maintain their housing. The same thing goes for someone engaged within mental health treatment. And you know, we had mentioned this already, that harm reduction does not have to be exclusively focused on substance use. There's a lot of other ways that we can utilize minimizing risks, and we're going to talk about what that looks like a little bit later, but how to minimize risks in the midst of not having as much control over a situation in a variety of situations. It really should be participant-driven. It's where their own goals are, and it acknowledges that participants can heal and recover in housing rather than on the street. Some of our other core philosophies are that we believe that everyone deserves a safe, permanent place to live. We see that housing is a basic human right, not a privilege, not something that they need to earn, not that we just dole out because, you know, they're deserving of it, but we feel, or not just because we have something to grant. No, they need a place to live. That's how they're going to be able to recover. That's how they're going to be able to achieve wholeness. This is a resource that we can share. We believe in the inherent worth and dignity of all people. Safety and stability is often going to be achieved much more easily after a person can move into housing. Again, hand in hand with harm reduction. I heard the metaphor or the simile, I don't know, simile. I heard the comparison once that saying, should we be talking about housing readiness, especially when, for instance, a person would be going to a soup kitchen or going to get something to eat and they don't have anything, they're hungry. We don't ask them, are you food ready? No, instead we say, you need something to eat. We will get you something to eat so that you no longer are starving or that you have sustenance. Same thing needs to be applied to housing. A person does not have housing, therefore they're unable to achieve any of their other wellness goals, their healthcare needs, all of that. We're also working off of the overall premise of the mental health recovery model, which I'm using the SAMHSA definition here, that recovery is a process of change through which individuals can improve their health and wellness, live self-directed lives, and strive to reach their full potential. Again, because this is not necessarily my definition, I'm just going to briefly touch on it because it's setting a tempo for the rest of our presentation. We see this as working with a few different main dimensions. This can be in their health, so overcoming one's own diseases or their symptoms, in their home, so having a stable and safe place to live. Purpose, so and a lot of times we do hear this within recovery language, or we hear this with a person working on substance use, is that they need to be able to supplement maybe their time that they had previously that was so focused on substance use with meaningful daily activities. And it also can be a big piece of recovery from homelessness or recovery from that process, reintegrating back into a community. Doing things like a job, school volunteerism, family caretaking, creative endeavors, and them developing the independence, income, resources to participate in society. Finally, the last dimension is around community, so that they can develop relationships, social networks that provide support, friendship, love, and hope. Also contradictory to a lot of the more traditional models is that harm reduction works hard to avoid shame. And shame, unfortunately, is just built into our culture. We see it all the time. It's used as a tactic to try and motivate people, but that sets a massive wedge in between our participants or being able to serve them in an effective way. And so harm reduction is trying to avoid those things and align with a person to develop a trusting, more open relationship in that sense, working off of a lot of the motivational interviewing type skills that we discussed in the first webinar. So let's get into some more definition around what actually is harm reduction. And I'm using a lot of the stuff here from the Harm Reduction Coalition. They are one of the main organizing bodies around harm reduction. Big thanks to them. A lot of the materials and information that I use throughout this presentation can be attributed to their work, and they do some really amazing stuff for a lot of organizations across not only just the United States but beyond too. So defining it, it is a pragmatic and compassionate philosophy that accepts reality that people may engage in high-risk behaviors. Again, this is not exclusively focused on substance use, but we recognize that people will still engage with these things, but we want to be compassionate. We want to be available. We want to find ways to still keep them engaged and not just relegated off into the shadows, into the margins of society, to still minimize the risk and the suffering that they would go through. It's also a set of practical strategies and ideas aimed at reducing the negative consequences associated with those risks. So it's a what can we do that is not just an overall philosophy or a guiding thought system, but what are actual practical ideas that will then minimize those consequences associated with risks that somebody is likely going to still engage with, but then bring down their suffering, bring down their impact to society, their impact to community members, to family members, on and on, but primarily that person themselves. Finally, it's a movement for social justice built on a belief in and respect for the rights of people who use substances or engage in other higher risk activities. We don't just ignore those folks. And so we recognize that we still need to include everybody. I see harm reduction as a very inclusive spectrum. It's an overall umbrella that needs to include a lot of different things. sometimes our folks who are our staff who are really strong advocates for harm reduction, they might feel like it's harder to include just total abstinence, for instance, within the umbrella of harm reduction. I don't think that that's true at all. I think that it needs to include those things if that is the goal of the person. But it also can be all the way at the other end of the spectrum, from safer techniques to still engage within those risky behaviors if a person is still choosing to do so. And then in the interim, in the between, how to manage that use, for instance, and then all the way across the board. The idea, too, being that maybe without harm reduction, somebody might be engaged in something that is very chaotic. It represents a lot of, it's all right in the name, the harm towards themselves, and how do we minimize that chaos that they would be experiencing. Another important part of harm reduction is recognizing that there's a continuum of use, especially when someone is engaged, particularly around substance use, is that we don't treat all aspects of substance use or engagement within those behaviors as the same thing. So sometimes in more traditional settings, you might look at it and to say just this one little time or occasional use is just as problematic or risky to a person as someone who is doing it all of the time. But we need to see that there's a continuum of use, and how we respond to it, the practical interventions that we can offer to a person need to fit along that continuum. We need to recognize where a person is and then adjust our approach based on that placement. I really like, this is actually based on an article focused on harm reduction within healthcare settings, and there's a handful of different overall principles that were there, and I have it in the final citation of the whole presentation here. But I like a lot of the components of this because it's pulling out that there really should be humanism built into harm reduction. So it's about that overall dignity. There's pragmatism, that we're practical. We recognize that there is a reality base to this, that somebody may still engage within behaviors. But it's also about the individual. We're trying to do this on a case-by-case basis. We saw this a little bit within motivational interviewing, but we're also trying to work with incrementalism sometimes too. Just the fact that a person is engaging with us and taking small steps can make big differences over the time, but they need to also feel like that the changes that they want to make are a thing that they're agreeing to do themselves. We can't force anybody, especially some of the circumstances that individuals are facing with, for instance, the opioid crisis that's happening right now. If we force a person into a particular mold, it can be very, very dangerous for them. Autonomy, too, a person needs to be able to feel like that they have the freedom to be able to make their own choices. And then finally, the one that we are going to talk a little bit more about within this, but I really like, and I think that it's a very important thing to highlight, is accountability without termination. So someone still has to be accountable to the behavior that they engage with, to the decisions that they make, but not without us withdrawing all services or saying that we won't help you just because you do X or you are continuing to engage with Y. There might be a consequence for it, and that could be natural. Again, we're going to talk about that more later, but I think that that's an important thing to still highlight. There's a couple other things. Engagement with the treatment is one of the primary goals, and that continues on. It's really helpful that a person has someone that they trust, that they will continue to come to, that they feel like, you know, I can actually talk about what's going on in my life instead of having to hide it, that you're not shaming them. And because they get to know you, because that they can trust you in that process, some of the goals and strategies to help them will develop in the therapeutic process. Right now we want to take a quick break, just ask for if there's any questions while we've gotten into some of the overall philosophy of harm reduction. I did see one person raise their hand, and Brandon's going to help us with some of these questions.
I actually don't see any in the Q&A or in the chat box at this time.
Oh, okay. Did anybody have anything that they wanted to bring up? It's okay. We can pause for a moment if they did. And it's okay also if we'll move on. If not. Maybe that person that raised their hand, and if they wanted to type it up, we could also save it for the next break that we'll move on. Nothing?
Doesn't seem like it at this time.
All right, great. Well, then I'm going to hand this back over to Oksana.
Alrighty. So now that Matt talked a little bit about what harm reduction is and its philosophies, we wanted to also talk about what harm reduction is not. You hear a lot of controversial statements about harm reduction, and people say that it's enabling, that anything goes, when in reality, harm reduction does not embrace or encourage any drug use or high-risk behaviors. What harm reduction is recognizing that this person has made a decision and acknowledging that decision, hence the autonomy aspect that Matt was talking about, and then working with that person, together with that person, to come up with ways to minimize or reduce risks associated with that particular decision. So if the person chooses to or makes the decision, I am not ready to quit drinking vodka right now, we would work with that person to come up with ways to either minimize, either reduce the amount of alcohol, or maybe even substitute it with, instead of buying 2 gallons of vodka every week, can we settle for 2 six-packs of beer? It might be a little extreme, but like working with that person to find ways to minimize the risks involved. Or if a person, when they drink, if they have a tendency to fall or black out and hurt there's a risk of them hurting their head or any other body parts, like you want to come up with creative ways to minimize harms that might come out of that particular behavior. We actually had a participant who would wear a helmet just specifically for that because he was drinking pretty heavily, and he would fall, and to minimize, to prevent any kind of head injury, he was wearing a helmet. So harm reduction also does not dismiss abstinence-based treatment models. There might be a preconception that harm reduction doesn't recognize again, it kind of goes right along with the myth that it encourages drug use. No, harm reduction embraces abstinence if that is what the person is ready to do, if they're in a position to say, you know what, I want to do this, I'm ready, help me, and then we'll work. Even with someone trying to quit drinking, for instance, there may be risks associated with stopping the behavior immediately or cold turkey, so we would work with that person to come up with creative ways to minimize those risks. We don't, or as harm reduction does not minimize or ignore the harms associated with drug use, sexual activity, or other high-risk behaviors. What we do is that we recognize that the person chooses to engage in those behaviors, and we work with that person to come up with ways to minimize any risks associated with a particular behavior.
If I can actually just quick normalize some
Sure.
things that we do within harm reduction, not just doing the work that we do all the time, but for instance, even just having a designated driver, for instance. That's something that outside the bounds of a Housing First program or a substance use program, someone would say that the risk would be, okay, so I'm going to be drinking tonight, but I'm designating someone to help minimize the potential risk to myself or other people, and therefore I'm going to remove that, potential harm. And it's really interesting. We make these choices all the time. We think it through. You could also think about it in a really basic sense that, like, I have high cholesterol, but I'm not necessarily being punished for eating a cookie, or I really like bacon. But we do punish people all the time just as a system for engaging with other kinds of behaviors that, yes, granted, they are they could be illicit uses of substances, but we also recognize that oftentimes they're probably for some sort of an adaptive reason too, and how we can then intervene with them to support them is important. Sorry for jumping in there, Oksana.
That's okay.
Oh, did we lose you? Hello? We're having a storm here in Philadelphia, so hopefully nothing is going badly.
How's
there
it now? Okay, good. So some of the criticisms you may have heard or you may hear about harm reduction are that it encourages use. Well, if you, we just actually talked about the complete opposite of it, that it does not encourage use, but it recognizes that a person or people in general will engage in use, or they will not take their medications, or they will not really abide by the strict diet that they need to in order to control their diabetes. Harm reduction sends mixed messages about enabling. Again, another myth. I think this is where folks may struggle with the most, trying to find the balance between harm reduction and enabling. At what point does harm reduction turn into enabling? People may see that it is enabling when you suggest to the client, hey, I recognize that you're not ready to stop using opiates, for instance, but how about putting some preventative measures to minimize you getting Hep C, for instance, or any other, like HIV or AIDS? How about connecting you with a clean needle exchange program? That way, at least the harm of getting physically ill, getting the Hep C and other illnesses will be eliminated or significantly decreased. Another myth, which I'm sure many of you have heard, that harm reduction fails to get people off the substances. It's actually the complete opposite. Because we don't push, as harm reduction practitioners, we don't push people we don't force them to stop engaging in particular behaviors. We actually work with them at their pace using motivational interviewing, that person-centered approach, to help them move along the continuum of the stages of change. So when they finally are ready, we're actually right along their side to provide all the supported services that they may need. If you are from a philosophical approach that it's abstinence only or no other way of recovery, and you mandate someone to treatment or force them to stop using drugs, it might work for a very brief time. It might work for the 30 days that that person is in inpatient rehab, for instance. They might not use any substances, but that does not mean that what it means is that they're very likely to re-engage in those risky behaviors or substance use right after they complete the inpatient treatment. We actually see that happen a lot too. So force, authority, coercing someone to stop whatever behavior they're engaged in doesn't effectively work. The opposite of the first column is you may see that there's tons of literature that supports that harm reduction actually works, and it's been pretty effective in helping people recover or maintain recovery at their own pace. And abstinence, obviously, is not the primary goal. The primary goal is to minimize risks associated with whatever behavior that person chooses to engage. We do encourage abstinence. However, it's not a condition that we present in front of the clients. We don't say you must be clean in order to do X, Y, and Z. But we'll say
I'm going to catch you on your language right there, Oksana. You said the clean word.
Thank you. See, we do this all the time.
Yeah, but that's actually a good point, is that like we're always kind of challenging each other and thinking about ways that like, okay, well this happens, or we say this, how can we help maintain an accountability around it on behalf of our participant? And I tell my staff, please call me out, just the same way that I'm going to do the same thing with you.
Yep. Thank you, Matt. That was actually perfect. So I know earlier in the presentation I did talk a little bit about not taking things personally. This is really not about you. We do recognize that your values, your biases, what's important to you may play a role in, or you may get tempted to put those values as factors in your decision making. But it really, when you make a decision, when you work with participants, this is not about what's important to you. This is not about what you believe is the right thing to do. It's really putting that participant's shoes on, putting their shoes on, and trying to really walk in those shoes and understand them and meet them where they are and engage with them so we can collaboratively work together. If nothing else, you do want to kind of remember this is not about you. It's not your agenda that we're pushing. It's not our agenda. What is it that this participant needs from me to succeed in whatever it is that they're trying to do?
So we're going to talk some more about some of the Harm Reduction Coalition's key principles and how these are displayed. And I actually want to talk about it a little bit more further within a housing context. I'm going to challenge you, too, to think about how that would apply within your own organizations, and think about maybe some of the questions that how that would work. You know, obviously we've been doing this a long time. We've been our organizations are built to do this, but your own context may have to really struggle with it a little bit. You might have to battle a little bit against a system that's not entirely sympathetic to it, or is going to struggle with the ins and outs of this. And so how can you then incorporate some of these components into your own work? And I would invite you to think about those questions. Feel free to ask us as we take our next break. We're going to actually stop. We'll make sure to stop after we go through each of these different principles. So I'll briefly review them here, and then we'll go a little bit more in depth in each one. This includes the overall health and dignity of a person. We are very focused on a person's health and wellness. Now, that doesn't mean that there might be significant risks associated with the decisions, the behaviors, the things that they are engaging with, but we are still trying to completely still educate, still offer all of the options, still tell what else is available in our toolkit of supporting them, but doing it in a really dignified manner. So we'll talk about that a little bit more. we've already noted, it's very participant-centered. It is their focus. It's not about us. We saw that in the previous slide too. This is about their goals. It also should be, it should involve it's participant involvement, so them making their own decisions. It's self-rule. It also recognizes injustices and inequalities, and then it's practical and realistic. So we're going to move on into a little bit more detail about these things. So within health and dignity, we're trying to find ways to foster the least amount of harm while also maintaining respect. So when we're minimizing the risks and maximizing safety, this should be applied into the individual context of that person that's in front of you. So if, for instance, we're thinking about a person in a housing context, and let's move it on away from substance use and consider hoarding, for instance. Someone who is engaging in some collecting behaviors, and there's significant risk because they have so much things in their apartment or in their housing location. But there's really, really important, they still really value all of this. We can't just ignore you know, that they are collecting books and papers and all of that, but there's a potential fall risk there, or there's something else that that might cause harm to them. So we're trying to talk about that with them, educate, but not re-traumatize them, or not cause them further risk just by ripping those things away from them or telling them that there's something completely wrong with them. Moving on again with participant-centered, as providers, we need to be able to offer services without judging that person, and our programming should be low threshold. It should be accessible. It should be something that is easy to get in. You don't want to have tons and tons of hoops. You don't want to have lots of barriers for a person to get access to the work, to the support that we're able to offer. And it's important to think about this. What are the barriers that are standing up within your own housing context? What makes it much more difficult for a person to get in, and how can we potentially minimize that? Maybe that there's some things that are institutional that's a little bit harder to take that away. It's big thing that happens from a city or a town perspective, and you being somebody that can be develop an alliance with them, you can still support them and walk through that. We do want to involve that person as much as possible. Providers can ensure that the people you are serving should have a voice in the creation of programs and policies, not just the goals that they're developing, but the direction of what you're doing as an organization, developing some of those policies. One of the ways that we have demonstrated this within Pathways to Housing is that we make sure that we have a monthly tenants committee where we invite all of our participants to come together and talk about what's happening in their housing, where they want to see further development within the program, and what are the important services that we can continue to offer to them, and then maybe there's some adjustments that need to happen from that. But it's their voice, and we're empowering them for that. So it's not just about us as the experts pushing something onto them because we think that this is the right way to go. It should also be about self-rule. So providers or us, we're recognizing that they're the experts in their own lives, and it's the participants who make their own changes when they feel like that they are ready to make them and under their own circumstances. This is a great application of the motivational interviewing skills that we talked a little bit about before. Well, not a little, we talked a lot about in depth in the previous webinar. When a person is ready to make the change, they'll do that, but we can't force them to take those steps unless they want to do so themselves. it needs to recognize inequalities and injustices, and this can fit into a variety of different contexts. We have to recognize the complexities of poverty, class, racism, isolation, past trauma, sex-based discrimination, and other inequalities, and all of these things can end up impacting someone's vulnerability and their capacity for being able to deal with behavior-related harm. What does this then look like for you within your own housing context? What are the things that stand in someone's way? Could that be issues related to poverty and the access of services that they need to do, or like the kinds of insurance that they might have, and there's only limited options that they could access for substance use treatment, for instance, or that they have to be involved in a really demeaning intake process for one particular program that is incredibly in-depth and not at all trauma-informed, and how can we then walk through them and advocate on their behalf in order to take those steps? And then finally, it's practical and realistic. So we have to come up with some of those practical tools and education to address the real harms and dangers experienced by individuals with significant risks. So looking at what is actually going on within that person's own life. And you know, we could spend probably an entire 2 hours looking at one or two of those practical interventions. We're gonna get into one particular tool that we use for safety planning for folks that uses some of the principles of harm reduction in a little bit, but there's a lot of different ways where this could be applied in a housing context, and I want you to continue to think about how you could practically use these too. Some basic examples, and I said this already, like we can talk about what this looks like, but it could also be simple things like nicotine replacement. That's harm reduction. It's recognizing that that smoking and cigarettes kills many, many people every year in the United States, and so replacing them with some of the other products or smoking cessation programs is very advantageous for a person. Engage in safer usage practices, so one person might be doing one thing, but there's a safer mode of being able to do that. Refocusing sexual energies during maybe a hypersexualized behavior. We've talked this through with some of our participants, and that they would definitely be at risk of either being arrested or maybe even assaulted by neighbors because of some of their behaviors, and how to help refocus them in a different way, that what's appropriate, how are certain things fitting into the wider context of what's okay within a overall community. Developing ideal use plans. So if a person is going to engage within a substance use, and this could look like, you know, in a really, really normalized or easily accepted sense, the designated driver idea. But then it could be somebody who, if they really are drinking a lot, how can they still maintain their substance use or their alcohol use or any of these other things, where it then doesn't become a major risk or a safety concern for themselves or other people, but they're still choosing to engage within that. So what's the safest way to do so? We do this sometimes with low-profile coaching for housing retention. So, for instance, like someone is, you know, if they are still drinking, they're still using, we tell people to think about how to have a lower profile. Your apartment should always be inspection ready, so that if a landlord or a maintenance worker or someone else comes by and they see just beer cans all over the place, or maybe you have a syringe out and someone's going to freak out about that, or they're going to be really concerned, and you might put your housing at risk at that point. How can we help you have a lower profile about your substance use, not hiding it, because you're still talking about it with us, and we're still trying to address the risks that are associated there, but maybe for somebody who may be less sympathetic of how to deal with those types of things. I already talked a little bit about reduction of hoarding behaviors, and we're going to look at it in a case study later. Switching maybe from a higher risk substance to a lower one. Oksana noted that really briefly for a person maybe drinking significant amounts of vodka, for instance, and then they want to still use alcohol. Well, maybe we're going to switch over to beer. Or someone was previously using cocaine, and but they really don't want to take those steps. Well, how can we help you think about something else? Again, on a spectrum to figure out another way to minimize those risks. Medically assisted treatment actually is an example of harm reduction. So these are things like methadone, Suboxone, Vivitrol for addressing opioid use, and we're engaging with that a lot. We have a new team that we've been working with at Pathways for about 1.5 years that is all for individuals with opioid use disorder. Safer sex practices or STI prevention, so even condom use, these are all harm reduction, and knowing that a person is exposed to risks like that. What's the method of delivery for using a substance? For instance, if someone is smoking versus injection, there's different kinds of risks that a person could be exposed to by using one versus the other, and educating them about that, and then helping them to, again, minimize those risks. Could be doing things like syringe exchange. I know that there are very, very minimal amounts of where those are available across the state. We have a fantastic partner here in Philadelphia that we work with for folks who are dealing with opioid addiction and heroin use. Repeated overdose education and safety planning, we're going to talk a little bit about that, but things like accessing naloxone or Narcan. Telling people to not use alone. So if they're engaged in a behavior and if they're just doing it by themselves, they have more risks. But if you have someone else looking out for you, you have less overdose risk. You have less possibility that you're going to have other health concerns occur because of that substance use. That can be problematic, and like it's not just it's not just a matter of don't use alone. Like that, there's much more conversation that needs to occur within that. But it is it's one tool in the toolkit. Money management for substance use budgeting. So maybe a person who is blowing all of their money at the very beginning of the month because they're buying whatever it is that substance is. It could be alcohol, and but then they don't have any money left for rent or for the rest of their bills, for food later on. And how can they make sure that they set that money aside? We do this, you know, for what our own needs, I suppose, for that person to maybe say that, like, how do I help take care of what's important to me, where they put their values, and then they are budgeting for it. I do want to take some other questions here in just a moment, but it also is really important as we are developing some more of our harm reduction supports to make sure that we're offering on-demand harm reduction. So if someone is asking for something, we need to make sure that we have those right at that moment. We should be educating about the needs of the folks that we are serving. So if we have a bunch of individuals who have significant amounts of alcohol use, we should know about what that means, what are the risks that they're facing, and how to be able to access things like detox, treatment, or other lower intensity interventions, not just hope that some other system will figure those out. If that's going to be a big impact to a person's housing, to the services that we offer, we should figure out how to do that. We should respect that a person can decline that because that's housing first, but continue to offer, make it available. We don't want to hit somebody over the head with it, but we'll keep coming back. We're still around. Hey, are you interested in this? Can we talk about this some more? What are the things that are barriers to you to access some of the other supports that we've talked about before? And there really is just a range of evidence-based programs that are out there that will reduce this. And I want to ask, especially now that we've talked about some of the other components here, if there are more questions, if you wanted to talk any further about what that looks like from some of our practical examples. But is there anything else that folks have contributed up to this point?
Yeah, I have two questions here. First one is from Scott. How can we practice harm reduction when clients are engaging in activities which can get them evicted and or denied housing for completely lawful reasons? Examples, drug dealing and attracting vermin because of hoarding.
Yeah. So, you know, some of our interventions are going to look very different between those two things, but those are not necessarily, like drug dealing is illegal and hoarding is not legal, or that it is legal. I mean, it's not a thing that's prohibited by the law, but it could impact the ability of a person to have a approved unit, for instance, like something that we've faced that it would not pass an inspection. And so we've had to figure out what are the ways that we can still support that person appropriately so they don't end up losing their housing as a result. And so we'll talk through the options, how they can still maintain their place. Am I hearing appropriately? Am I kind of, I know, Brandon, I'm asking you, and you're not the one who actually answered the question, but
we can add to that too, Matt.
Go ahead.
For the hoarding specifically, I know what we've done in the past is using these principles that you talked about earlier, maybe even the substitution or compromising on some things. We would work with a participant to create a safer environment, even if they choose to continue hoarding, but it would be somewhat of a managed hoarding. Like, let's say the height of the pile, whatever, or the boxes couldn't be like higher than 2 feet. You had to have a way to exit the apartment. All the windows had to be clean, but this required a lot of like negotiation and back and forth with the participant. But they finally said, you know what, let's do it. And I think it's because they felt that person-centered approach, they felt that they actually have a say in what happens to their stuff. We used their strength of, let's say they wanted to do something good to the greater society. We kind of used that as, how about you donate some of the stuff that you already, like it can help people in need. So using, I think, their strengths, using their, like, emphasizing safety and negotiating with them, but doing it in a way that you're not pushing, you're not exercising force and power, I think will go a long way.
Yeah, and in a really, really practical sense with hoarding too, what we found is that it's been really helpful to be very concrete with something. So for instance, like Oksana talking about height, we would put painter tape up on the wall and say, like, let's try and find a way to not exceed this level. Or that we'd put painter tape along the floor, and we need to make sure that we maintain paths so that if there's not enough of an egress to pass through a hallway, then it's not safe and we risk then losing this apartment. So being really, really practical and concrete with that person. What I would say around the drug dealing, for instance, that may end up being a natural consequence, but warning a person that, you know, we might, we're heading in a zone where you might lose your place. We don't want that to happen. How can we prevent that from occurring, and how can we help move these things along? And there's some really great tools that are out there for that. I'm happy to share them. We also can talk a little bit more about what that looks like in our in-person trainings that we're going to be doing in May for very practical applications of some of these things.
And also to add to the case with the drug dealing, I would, if you want to use one of the harm reduction principles, I would probably want to know the reason the person is, this may sound really funny to many, but explore the reasons or the adaptive behaviors, the underlying reasons why the person is engaging in this behavior. Is it because they need money, or do they feel intimidated, or is it for completely illegal reasons? So I think the reason will also play a role into how you design the intervention with them.
Cool. Do you have another question, Brennan?
This one is actually more of a statement or a concern from Sarah. She works for the Women's Resource Center, and she just wants to touch base on the language that was used for the sexual energies. She says that person choice to engage in sex if consented, but if it's an assault, that is not their choice, and that is victim blaming.
It's a good thing to note. We're not, I don't think that we are, well, and I apologize if we're saying anything that would be offensive in that sense. The individual that I'm particularly thinking about is that someone was not engaging in assaultive behaviors, but that they had, they were more hypersexualized in their outward. They were often masturbating out in the community, and we were trying to help them figure out other ways to refocus their energies so that they were not out in the community so that other people did not feel like that it was being imposed to them because they felt threatened by those things. I would hope that that's not the image that I'm giving for that particular situation, but I understand your concern though too from Sarah. Any other questions?
That is all I have at this time.
Great. Okay. Cool. All right. So I'm going to give it back to Oksana.
Alrighty. So when you practice harm reduction, you are, well, some of the outcomes of harm reduction are, as you can see here, it's one of the most prominent ones is that it increases the trust and fosters engagement, higher level of engagement with clients or participants. And you might think, why is that? Why is harm reduction so special that it increases trust? And it kind of goes back to the philosophy of using that person-centered approach, highlighting their autonomy, the decision-making, and respect that Matt talked about earlier. When you convey those, when you practice at least those three items that I just noted, it is going to help with your engagement and the trust and relationship with clients. On a wider sense, well, the literature supports that harm reduction improves the public health with individuals and community. I think like we can actually use the example that Matt just talked about with that particular participant who would masturbate in the community by finding creative ways to maybe like do it in their apartment or not doing it in the community. You're actually you're improving, how do I say, you're removing the harms that the community members might be exposed to otherwise. Or the needle exchange program. We actually provide for those people who use opiates heavily, we provide sharps containers where we encourage them to dispose of the needles in a safe way. That way they're not either like keeping it in their apartment, or you don't really find the needles in the community as you walk along the neighborhood. So encouraging those little things will go a long way for the greater good, just as for the individual as well. And as Matt talked about earlier, with shame and harm reduction does not necessarily encourage shame. It stays away from that, and it promotes the challenging of the stigma by highlighting that every person chooses or has the right to make choices and follow their choices. And again, we're not talking about illegal activities. We're talking about their decisions to take medication, their decisions to keep or not keep the apartment clean, their decisions to dress certain ways. So those are the principles that we highlight, that a person has a right to make those choices, and we do reduce stigma by recognizing and respecting those choices that they make, despite of whatever challenges they may face. So I know Matt talked a little bit about the accountability aspect of the harm reduction. One of the myths that we also brought up was that harm reduction might be enabling, and this is actually a complete opposite of that particular myth. Harm reduction does recognize that there will be or there are natural consequences for certain behaviors that you choose to engage. Again, we're highlighting the choice here. So let's say someone showed up to work high or intoxicated. What might be the natural consequences of that? That person might get suspended without pay for a week, or they might get terminated, and that's something that that person has to be able to accept. Are they posing a threat or a disturbance to their neighbors? If that's the case, this goes back to one of the questions you asked about evictions. That might be a natural consequence that after we implement certain things, we engage with you to come up with plans and continue to expose the immediate community, for instance, to disturbance, you might actually end up getting evicted from that apartment. Are you neglecting your bills or rent? The same thing, you might end up losing that apartment. And it doesn't go from the black to white or from one extreme to another. We will work with a person before they get the eviction. But again, if they continue to choose, highlighting the word choice here again, to engage in any particular behavior, there will, there are some consequences, and we're not kind of protecting them from that, because if there was no accountability, there would definitely be enabling in harm reduction.
There's also oftentimes the people that we serve end up getting either scapegoated, or that because there is the stigma question, or somebody might jump on and say, well, they're the reason why this is happening in an apartment. And so this does need to sometimes be a place where we just don't say, well, this is the natural consequence of whatever their behavior was. We sometimes have to also figure out how to advocate on behalf of our people, not just saying, well, they did this and they did that. But you walk this line, how to help stand up on behalf of them. We'll talk a little bit more about that in a bit.
So one of the tools that Matt referred to earlier that we use pretty much with every participant is our safety planning tool. It is very person-centered. It's actually, it was redesigned or reworded in a way to make sure that participants of different levels of education could read and understand and relate to the safety plan. We removed, I think, pretty much all the clinical jargon off of the tool. It was originally designed to help with suicidal behaviors, to help prevent, I guess, the crisis of suicidality. However, we were able to adapt this tool, and we use it for many different behaviors that might be risky that participants choose to engage with the intent to minimize or prevent, so to say, the crisis. We're going to present the tool in the end also, but you can totally adapt this tool for your own agency, make it work for you, change the language, but the philosophy is that you work with a participant through this tool to help them identify some of the warning signs, some of the ways they can cope with stress or whatever warning triggers, warning signs they identify, what resources that they may have they can utilize to support themselves, how to make that environment safe. Professional supports, this is kind of going in the sequence. We do encourage we empower participants in a way that we encourage that they use their internal resources first before taking the step of involving professionals. Unless there's a crisis and a medical emergency, then of course you would have to go through probably 911 or go to the ER. But we're referring to, let's say, we'll use an example of, let's use an example of, I don't want to keep bringing up the drinking, but like a substance use or getting into fights. We can use that one. If you have a participant who physically gets into fights and gets arrested as a result and accrued all these fines, let's say that you want to work with them on developing specific step-by-step instruction or a plan on how to prevent you getting angry or upset at something, how to prevent that from escalating to a physical assault of another person. So a warning sign might be for that person, I start having thoughts about hitting someone, or I start thinking that everyone around me disrespects me. That can be one warning sign. It can be kind of internally recognizable warning signs, or it could be like physical warning signs. I start sweating a lot, I start shaking, I start pacing back and forth, I start having worry thoughts, whatever it is. It's going to be very specific to the individual. And then you would want to ask, like, how can you, what are some of the things that you can do yourself to help you cope with these warning signs? And the person might say, well, every time I start pacing back and forth, I can actually sit down and take a deep breath until I calm down. Or I can tell myself that I'm not going to do it this time. Using positive self-talk is a big thing. It's very easy. Participants can do it. Use a mental distraction, whatever it is that works for them. What other supports do you have? Can you call? Who can you call? Let's say, do you have any friends who can help you? Who can help you through the situation? And they might say, yeah, I have a friend. Every time I talk to him, he really helps me out. He keeps me calm and level. So you make a plan to, you write down that person's name, their phone number, and you make a plan to use that as a resource if all the other ones don't work. Professional supports, again, case managers, we have teams that are available 24/7. So, but again, it's kind of as a last resort. If all of the things that you tried didn't work for you, and it is escalating and you're really about to go out and start hitting people, and I'm using an extreme example, please call the team. Please call, if there's a fire in your apartment, 911, or get out of the apartment. If you're having chest pains, go to the ER right away and then notify the team, or, you know, however it's going to work. It's important to follow those steps. One of the really key things about the safety plan that it is the participants' document, so we usually kind of develop it together. It's great if they can write all of these things down themselves, or you can ask them, are you okay with me writing down? Sometimes they'll ask you to do it, but the idea is that they have to keep the original with them. And as a provider, you can make a copy or two. Sometimes we'll give participants a couple different copies and the original so they can actually have it visible. Let's say I want to be able to see it every time I wake up, or I want to be able to see it on my refrigerator. It's really going to help me. Some people choose to keep it and carry it in their wallet. So wherever they can easily access this and utilize this way, you really should encourage for the participants to have it. It's really most effective if you complete this treatment safety plan before the crisis happens. So we usually complete this safety plan with every participant at intake, unless otherwise indicated. But let's say you completed one at intake, you already have it, and as you get to work with a participant, you get to know more stuff about them, and you can actually revise the original one or complete another one, and you don't want to forget about the safety plan once you complete it. It's always good to kind of have this conversation going about the safety plan, about the steps that the person agreed to take, and kind of checking in, how's that going? You said that last week you were pretty upset with someone. Did you use the safety plan? Did it work for you? If it didn't work, what didn't work? And let's come up with other ways that we can make it work this time. So some of the language, again, we revised it that we used, things I can do myself to take my mind off my problems. You can see this is very participant-friendly or user-friendly. It's not a medical document, so it's pretty easy for them to follow and read and use. This is the sequence, like, again, step 1, call friend number 1. If that doesn't work, call the other friend. If no one answers, maybe I'll take a walk, or I'll do the breathing exercise, take my medication, or call my doctor. So there are steps. It kind of progresses. You're going to start with the least severe or the least complicated step, and then if that doesn't work, you're going to take it up a notch. So we're actually going to show you the safety plan. It may be hard to see, but to read it, but this is what it would look like. It is a 2-page document, and like I said, you can revise this and modify it as you need to. But our participants know what their safety plan is and who are the people they can call, what are the places that they can visit when they need to. So fold it up. I encourage them to have it on them, in the apartment, wherever else they can easily access this.
Yeah, and something else to highlight within this is that like there's a lot of ways that this can still be adapted to think through. Like it's not always sub risks the person might be exposed. Again, we said that this was originally developed for some of the other concerns that are that a person might be experiencing, but there's ways that you can sort it out on your own for fitting with your own context. Moving on a little bit here, and we're going to do a little bit and then take some more questions and then go on to some case studies. But you have an opportunity in working with with harm reduction is overall challenging stigmatization. There's multiple levels on which this can happen. This is one of the core principles, again, of the overall philosophy. And this will happen at both the individual level. It could happen at a staff level, so maybe at an organizational one, but like just maybe peer-to-peer with you and other coworkers. It could be simple as me calling out Oksana and saying, you know, just that one language thing, and you know, we have that relationship. We can do that. We have done other times where where maybe I've said something that doesn't fit appropriately too, and I really want to be able to invite that. And then it can also look in much more wider sense of what that looks like for the community and how we can help be inclusive and supportive for other individuals too. At an individual level, that can be thinking about just the language that we utilize. It can be trying to be honest to ourselves. It can be honest with that other person. We're not trying to be desperately honest that we're just hitting someone over the head with our honesty. That, well, I'm just honest, and like that's why I said this thing. Well, no, it's still trying to be honest, but like in a supportive, respectful manner. It's by developing relationships and having that be in a supportive, therapeutic manner. Sometimes it can actually even look like disclosure and talking about things that we have gone through ourselves, or recognizing that someone else in our lives have gone through something with addiction or something with trauma. The really, really important thing within disclosure is, are we doing this on behalf of the other person, or are we doing it for ourselves? And if it's ever for ourselves, or we're doing that because we feel like, well, this will make me feel better, or this is like, now I think that I'm going to connect up with this person, then we shouldn't do it. We should avoid disclosure at that point. But then being able to use that as a means to have dialogue, to have a person build trust. It shouldn't be all the time that we're talking about our own experiences with a person unless they feel like that they can trust you on that anyway. Other ways is through further educating yourself, making sure that you're finding means to learn more and more about if it's something within substance use, if it's finding out about things with a person who has experienced trauma, for instance, or a variety of other ways, and how that impacts your participants. You can do more and more personal development, so you deal with that on an individual level. If we're looking at it at a staff level, so your organizational perspectives, that can end up being, you know, how to invite and welcome in more and more training and education, trying to find out where are these levels, these outlets for feedback, maybe that there's components where somebody doesn't feel safe or feel like that they're able to talk these things through participant-wise. And they've said, I really don't like the way that this is done, or I always feel judged by this, and that they should be able to express that, and then that goes someplace. It doesn't just go into a box and it sits there and gathers dust. But we need to always be assessing our practices as an organization. It's really, really important too, is hiring peers. And, you know, again, I'm calling them out my own language here, but users or somebody who is also in, those in recovery themselves, and that they've gone through these types of experiences. They can connect up with participants or like that we've experienced in some sort of aspects of addiction or loss related to those things. We can know what that looks like for everyone else who we're serving. You're being much more inclusive at that level. Then finally, at a community level, that could be doing awareness campaigns. It could be trying to develop a participant advisory board. So like maybe somebody that you're serving, and that they could then talk further about what it's like to go through these types of things. We could look for ways to do further policy or advocacy, talking with legislators or talking about other things going on, and then events too, so that folks have a chance to have exposure, that we're not just it's just a story or there's just some myth about what those people are, but no, there's an opportunity for people to learn more, to be educated, to be exposed, and bring down that stigma. So before we get into the case studies, I wanted to ask if there's any more questions, or if people have some feedback here. Do you have thoughts, questions that have come up so far? Nothing? Brandon, you got anything for us?
There is nothing at this time.
All right, great. Well, so we want to look at a couple case studies here. And the purpose of the case study is that we wanted you to think a little bit about some of the principles of harm reduction and apply it to these situations. What are the things here that how that can be demonstrated? They're not exhaustive. The case studies are also, they're pretty brief, and so there's probably things that I missed in pulling them out. There's other ways that can be that it could be demonstrated more and more. But we're going to read through them, and maybe there's things that you see that could have been highlighted or supported, offered to the folks that we talk about within here. So Oksana, you were going to lead that?
Mm-hmm. So we have Reggie, who's a formerly homeless individual working with your agency around housing and behavioral health support. He has a long history of alcohol use and is diagnosed with Hep C and cirrhosis. He drinks vodka at the beginning of the month and switches to mouthwash. He shoplifts at the end of the month when he runs out of money. He worked with you to get into detox and treatment twice in the last year, but is currently drinking again. He notes a slight interest in moving out of the area where there's a lot of triggers, though. He has grown up in the neighborhood, does not have supports anywhere but here. Neighbors report to the property manager Reggie is friendly when sober, but are about done with his crazy when he's not. They know he has someone working with him, you, and try to engage during visits. His landlord regularly complains about his behaviors in his apartment related to his intoxication.
So I want you to think about, like, what are the things that immediately stand out to you on each of these different categories, and what are the things that you need to think through a little bit further when you dig down deeper. I pulled out a few at a practical level. Some health needs. We know we're seeing him talk about the Hep C and cirrhosis, but also there's major risk for the degree of alcohol use that he's doing, and on top of that, he's switching over into mouthwash, which we do have some participants who this is actually based on a couple of real people that we work with. There's a lot more health concerns based on this for someone, and so then we need to think about the substance management for this, so that there's vodka versus mouthwash. Maybe there are other ways to highlight supports for them. Money management concerns for Reggie, budgeting for alcohol, since he doesn't switch from a higher risk substance like mouthwash. But then on top of that too, then he's got exposure to the criminal justice system because he's shoplifting, and he may end up with more and more either court fines or citations, being arrested, going into jail. And how can we help him avoid those things too? If we're looking at his own client direction, he's working with some ambivalence around treatment, and I think that's true about the fact that he's actually gotten into detox and treatment a couple times in the last year, though he's currently drinking. So there's something there. If he had utterly no interest whatsoever, then he might be less likely to have that ambivalence. But because he's done it in the past and relatively recent past too, there's something to work with. So what we likely need to make sure that we've got locked and loaded for Reggie is on-demand access to treatment, and then maybe other harm reduction supports too. What would that look like in the context of this? Maybe there's some other advocacy needs. You saw the quotation of what I call the C word. We really try and avoid that as much as possible at Pathways. Is the crazy, and is he getting scapegoated, or is he being blamed for other problems? Maybe he is actually posing some sort of risk within his apartment too, and maybe we can talk about the behavior things and minimize the risks to him potentially losing out on his apartment because of that. Are there other things that you see or other thoughts? Anything else? And you don't have to necessarily call them out. Maybe you want to type something up or ask a question about this, or you can just think about that too for this particular situation. I'm going to move on to the next one.
So Michaela had been engaged for years before she came into housing 3 months ago. She more or less sees her apartment as a storage top of her ever-increasing collection of things like books and other items, chain smoke, cigarettes, and sleep at night. Her landlord complains to you regularly about the accumulation of items he believes is there and the smells that are coming out from her apartment. Michaela has said she likes being away from the cold and doesn't like the threat of being hassled by cops or having her stuff stolen while on the street. She has limited mobility issues due to her need for a hip replacement. She has not wanted to engage in medical care but complains about pain. She has self-medicated with illicit substances for the pain in the past, which she denies now. The accumulation of items in her apartment has posed a fall and collapse risk for her.
So let's think about some of these principles again for Michaela. And you may recognize Michaela actually from a case study from our last webinar. We expanded a little bit more to get some more details, but she was someone that we talked a little bit about with our motivational interviewing session. So some of the things that stood out to us was things related to her health needs. So there's chronic pain and how we could help her deal with those things. There's the overall need for hip replacement too, that maybe this will become severe for her at some point, and how that will impact her overall mobility, her access to autonomy, living independently, how to what that'll look like for long-term care. There's also a fire risk, though, for her potentially smoking in her apartment and then significant accumulation of items. And if she has limited mobility, for her to be able to get out, there's some other risks there that we need to be talking about, how we can foster her overall safety. But then also, how does that impact wider community safety or safety of those who are in the rest of her apartment building or neighbors? With substance use management, maybe this is nicotine replacement. We don't get into real heavily what the details of the pain management of the illicit substances are for the purposes of the case study, but are there alternative options for her for pain management? Can we access some of those things that are out in the community, or talk through some mindfulness practices that she could engage with, for instance, and offering any of those options? Client directions, this is similar to the last one. There's some ambivalence about the reduction of behaviors, but working with that ambivalence too. I don't want to do this. I don't want to change this, but there's something there. She did want to come in. She doesn't want to be hassled by cops. She doesn't want to have her stuff stolen. So there's something that still is an important value of hers, and it's connecting to those strengths. It's connecting to that value of what she has, and her wanting to still maintain her own autonomy, her own freedom, in top of besides maybe moving away from some of the other stuff that you very easily could focus on. What does it look like then for looking at some of her hoarding support? And we gave some really basic examples of that earlier, but there's a lot of really great practical resources out there for individuals too that's utilizing some of the techniques of harm reduction. And this is also similar to the last person of maybe there's some advocacy needs. Again, is she being scapegoated because of her enrollment in a program, or she being treated in a certain way just because a neighbor might see you coming by to see her, and then you're getting called in there and saying, like, you got to go do something about this lady. Let's look at our last case study here.
All righty. Ilana only just recently moved into an apartment through your program after 3 years on the streets. She has a long history of misusing Xanax and opiates. She's currently using heroin. She previously was engaged with a methadone maintenance program, but she was discharged due to non-adherence. She said she hated being in groups because it aggravated her anxiety. She would like to re-engage with some sort of medically assisted treatment or therapy. Ilana was hospitalized last week for a severe abscess on her foot. She received a skin graft in order to save her foot. She has had a very difficult time in the hospital because she feels they're not medicating her pain. She called you to tell you she was considering leaving the hospital, AMA.
So for this might be immediate stabilization and affirmation of your support. One of the big strengths is she's engaging with you. She reached out to you to say, like, I'm going to leave. I don't want to do this. What that's communicating to me is that Ilana didn't want to do that, but she wanted somebody to advocate on her behalf to help her deal with what was going on. And a lot of times, actually jumping down to our advocacy needs, is she being medicated appropriately? Is there some sort of label on her just because she had come in with an abscess, or she was labeled as an opioid or a substance user, that she's not getting the appropriate kind of intervention that someone else may have access to? And Ilana is based on a very real person that this is all very similar to debate, and we had to advocate hard on many people similar to Ilana. And there's certainly other health needs that we would need to think through for her, things like her abscess care, but then also major overdose risk too, because if she's using both a benzodiazepine like Xanax and also opioids, that's very, very dangerous, lethal mix. And how can we highlight that and find other means or other support for her? With substance management, harm reduction-based supports until the medically assisted treatment. If she's gotten an abscess, maybe there's something about her injection practices, or is she reusing needles, or is does she know about any other resources that might be in the community? Is she sharing them with someone else? And where is her overall readiness for change? It sounds like that she had done before, and then she also is interested in engaging in some sort of MAT or medically assisted therapy. And so how can we help take those steps for her, because that's her own goals. Though she's still engaged in the thing, we're not judging her. We're not telling her that there's something wrong because of that. And then the overdose risk too, so maybe talking about the Naloxone or Narcan. We're going to spend some more time talking about that in our fourth webinar when we get into a lot more of what this looks like for supporting individuals with opioid use. Anything else that you see with Alana, or any other thoughts with her or related to harm reduction interventions or support? It's okay if not. This is webinars are weird. It's hard to give feedback or answer questions. But as a quick recap, I wanted to say that harm reduction is a main tenet of Housing First. It's completely and wholly person-centered. The idea is that we want to start exactly where that person is. It should be very safety-focused and highlighting ways to reduce potential risks that a person is experiencing. We want to be educated as much as possible about the practical examples based on a participant's needs. And if we do not know about all of the ins and outs of what a person might be going through, or what, if they're engaged in whatever those risky behaviors or risk factors are, it becomes our job to learn more about that or try and pursue those things. And then we fight back and we challenge stigmatization too, because it's really easy as a society or as a system, or even our own coworkers or ourselves will ostracize them or judge them, and then that's just going to become a massive barrier in between that person being able to find some sort of wholeness or healing, or maintain their housing, their engagement with you, which ultimately, hopefully, is going to be able to be a really, really helpful support for them. So just one more big thank you to the Harm Reduction Coalition, and because I love so much of their materials. And but is there any other questions that you would have for us, or things that you would like to highlight based on what we've talked about so far?
Matt, Pam had a suggestion for Michaela, why she resists medical care. Perhaps she has a past medical trauma. Consider drawing up a benefits risk table with her regards to her health needs. For example, she may be fearful about recovering from surgery and the helplessness that goes with it. Offer support such as visiting nurses to help her get through. Point out that she can better maintain her independence if she addresses her hip problems. Educate her that she could end up in personal care of a nursing home if she ends up falling and breaking her hip.
Yeah, that's great. I actually, one of the things that's very, very helpful for a lot of individuals working with hoarding is very specific, concrete goals, and what you've noted there is very concrete in what you're going to be developing, especially when you end up drawing those out and helping it be very clear for a person. So that's great. Any other thoughts, questions, observations? No? Barbara, did you have anything further that you wanted to put in there?
I just wanted to say thank you. This was really, really informative. And I want to invite everyone back for Wednesday, April 18th for our webinar on trauma-informed care. And again, thank you very, very much.
Great, and we're ending a little bit early, but thank you so much for everybody for sticking with us, and we're really excited to be able to share this.
And I just want to point out, if anybody does come up with any kind of questions or concerns or anything, you can always email me, Barb, Lee. I don't know if you have Matt and Oksana's information directly, but if you have a question, we can certainly get it for you.
Yeah, and actually, so there's this email address that's on the last slide here, but I'm also happy if you want to be able to share out our email addresses, that's fine too. All right. Thank you.
Okay,
thank you, Matt and Oksana, for your time. We appreciate it.
Yeah, no problem. All right. Bye.
Take care, everyone.